I am Varun Puri. I am a professor of surgery at the Washington University in St. Louis and a practicing thoracic surgeon and health services researcher. Assessing if the entire cancer has been removed, or in other words, the completeness of cancer resection, is an important pillar of surgical resection for lung cancer. Firstly, why is it important for us to remove the entire cancer? We know from prior studies that incomplete cancer resection is associated with a much greater likelihood of cancer recurrence in the same field, which is termed locoregional recurrence, that is at the site of the original cancer or in lymph nodes adjacent, or metastatic disease in individuals. When we discuss the completeness of cancer resection, there are three terms that one uses. One is R0, R1, and R2. An R0 resection means the cancer resection was complete, no cancer has been left behind, and this has been confirmed both with surgical resection as well as the pathologic evaluation of the specimen that was excised. For example, in a lobectomy specimen, they would assess the bronchial margin, the vascular margins, which would be at the veins or vein stumps, or the pulmonary arterial stumps, and finally, all surfaces of the lung, which would be essentially the visceral surfaces of the pleura. And if all of those are negative, then one would term that as an R0 resection. An R1 resection, on the other hand, is a resection where cancer cells are present on microscopic evaluation. So one cannot physically see any cancer, either nodules or the tumor itself, at any of these margins we just discussed. But when the pathologists section it and look at the specimen under the microscope, they see cancer cells at those margins. Finally, an R2 resection is a resection whereby you have gross tumor, or actually visible tumor, present at any of the margins of the resection. R1 and R2 together combine what's called residual disease or incomplete resection. It's important to plan ahead of time to assess margins intraoperatively, as well as to make modifications to surgical resection in case one has a positive margin intraoperatively. There are two main areas where, from a surgical perspective, one has to assess margins. One is on the surface of the lung or on the fissures, and the second is at the level of the hilar structures. For example, on the surface of the lung, if there is tumor that we know is coming to the level of the visceral pleura of the lung, and there is chest wall involvement, then one has to ensure a negative margin on the side of the chest wall. This may involve either performing a full thickness resection of the chest wall or a subpleural dissection. So the lining of the rib cage on the internal aspect is the parietal pleura. And if the chest wall is adherent to the lung parenchyma, but there is no invasion of the muscle or the ribs, then performing a dissection in a subpleural plane by an experienced surgeon can provide negative margins. Otherwise, a full thickness chest wall resection would be indicated. Similarly, on tumors which are on the diaphragm, an en bloc resection, that means when you remove the lobe of the lung or the lung parenchyma with the tumor, you would like to remove the surrounding structure which is involved by the tumor in contiguity without separating the two, and thus avoiding any tumor spillage in the operation. The other component of assessing margins is the bronchial margin or the vascular margins, which will be assessed in the operating room. This is done with what's called a frozen section analysis. So as in patients who have relatively central tumors of the bronchus, we avoid what's called stapling the bronchus. In patients who have peripheral tumors of the airway, you divide the bronchus by stapling it, which is a device which cuts as well as closes the bronchus at the same time. In that instance, when one has to assess the margin of the bronchus, the pathologist has to divide the bronchial margin, excise 4 or 5 millimeters of tissue from the bronchus, essentially waste that tissue, which would not be interpretable, and then look at the margin which is above the level of the staples. So in any instance where you have a central tumor, you do not really cut the bronchus with a stapler. The bronchus is divided in the operating room with a knife usually, and the specimen is sent off to the pathologist to assess the margin. If the margin is negative, that means there's no cancer at the bronchial margin, then one closes the bronchus with sutures. Or if there is bronchus which is involved by the tumor, then oftentimes one undertakes what's called a sleeve resection or a sleeve lobectomy. It essentially requires excising a segment of the airway which was in continuity with the positive margin, and then sewing the main bronchus to the lobar bronchus. As an example, if one is conducting a left upper lobectomy for a central cancer, then one would divide the left upper lobe bronchus, check the margins, and if the margin of the left upper lobe bronchus is positive, then one would often undertake a sleeve resection, which involves removing the point where the left upper lobe bronchus attaches to the left main bronchus, and essentially as an anastomosis attaching the left lower lobe bronchus to the left main bronchus in the form of a double barrel. And this is performed by sewing those two structures together. So this ensures a negative margin in every direction from the bronchus. A similar concept is applicable to the pulmonary artery. One can perform what's called a sleeve resection of the pulmonary artery and reattach the remaining pulmonary artery to the central pulmonary artery. The importance of such operations is that these are parenchymal preserving operations. So in some instances, one might think of why not just perform a pneumonectomy and ensure that you have negative margins. It is a much better operation to perform a sleeve lobectomy in terms of short-term and long-term outcomes. Parenchymal preservation improves quality of life, lowers the likelihood of perioperative complications, and in general is associated with better outcomes. In addition, it's quite important for the pathologist and the surgeon to discuss where margins may be questionable. When one is performing a resection of a lung tumor, then a surgeon's input to the pathology teams as to what exactly constitutes a margin can be invaluable. This is particularly important in structures which do not have any other structure adjacent to them. For example, in performing thymic surgery or thymoma surgery, there is no structure which is adjacent to the thymus, and the lung, when it is deflated by using a double lumen tube, does not really have any attachments to the thymus. So if a tumor from the thymus is invading the pleura overlying it, one may see tumor at the margin of the resection, but since there is no attachment to any other structure to that thymus gland, one doesn't really need to resect or remove any other structure to obtain a negative margin. The tumor may be present at the margin, but there is no other structure which is touching that margin, so the resection would still be considered a complete resection. Additionally, intraoperative frozen section analyses are important for the surgeons and the pathologists to look at together. And in our practice, a surgeon will often carry the specimen themselves and walk over to the pathologists who are usually in a suite close to the operating room and assess the specimen under the microscope with the pathologist. An important part of assessment for completeness of cancer resection is how well one has established lymph node dissection or resection as part of the operation. An emerging concept which has been endorsed by the International Association for Treatment for Lung Cancer, also called the ISLEC, is the concept of R-UN, which is in addition to R0, R1, and R2 resections, an R-UN or an R-uncertain resection is one where the cytology may be positive in the pleural space, but it's something that is hard to document intraoperatively, where the highest lymph node station that was excised as part of the operation shows presence of cancer, or where there is carcinoma in situ at the bronchial margin. Many individuals, particularly heavy smokers, have a field change in their bronchial mucosa, where they may have dysplastic bronchial mucosa with carcinoma in situ present in numerous locations. So in that instance, if one is performing, say, a lobectomy, and one finds presence of carcinoma in situ, but no evidence of any cancer, it is unclear if resecting any more bronchus will ever get you to what's called a negative margin. You may find carcinoma in situ throughout the entirety of the respiratory tract. Therefore, one really does not conduct greater resections for only presence of carcinoma in situ at the margin. However, it is classified as an R uncertain resection. Importantly, the number of lymph nodes and the lymph node stations that are excised as part of an operation also increase the confidence with which one can uh, attest to the completeness of a resection. If one performs a lung cancer resection, there are certain lymph node stations which are often specific to a lobe of that lung, which should be sampled or dissected out as part of that operation. Finally, how does one address the presence of positive margins? This is usually a discussion that should be had in a multidisciplinary fashion, and the treatments can include either re-resection or using adjuvant therapy in the form of chemotherapy or radiation therapy. But oftentimes these decisions are made best in concert with a surgical, medical, radiation oncology team and a pathology team contributing towards the discussion.